You're very welcome to this video. It's Tuesday the 19th of January. We're going to be looking at data from the UK and the US mostly today. And I suppose the main bottom line to this video is it looks about 22% of people in each country have probably been exposed to SARS coronavirus 2. Now this data is a few days out of date, probably getting on for 23-24% of the kind of numbers. So we're approaching a quarter of the population being infected by SARS coronavirus 2 via natural transmission. And I think this just shows how important this vaccination program is. Because, of course, what this means is over 75% of our populations in the UK and the US have not yet been exposed and therefore are still vulnerable if it wasn't for the vaccination program. So without the vaccination program, it means we'd only be a quarter way through this pandemic. So it's pretty good news that we've got the vaccination program. Now, just a quick screenshot here. Here we see the current new daily confirmed cases. And we see that the US and the UK are pretty well identical. And we're going to be looking at some reasons why these numbers are dropping off somewhat here, which is good news. But almost identical per capita figures at the moment. So in many ways, very parallel situations, although there are a couple of things I am worried about for the states that we'll talk about. I mean, basically related to the new variant. Now, Office for National Statistics in the UK just published today, 19th of January. Now, they do this antibody survey where they're looking at the number of people with antibodies. Antibodies, as you know, made in response to the presence of the virus. The virus is the antigen. And the Office for National Statistics do it in collaboration with some pretty reputable bodies in the UK. So it's good quality research. Now, background science, just before we dive into this, seroconversion takes 2 to 3 weeks. So from exposure to developing the antibodies, 2 to 3 weeks. But the Office for National Statistics are saying they're not really sure how long the antibodies persist. It will depend on the way it's tested and on the individual. But it's not fully known. But we do know that the number of antibodies will decline, certainly after some months. It's a question of how long they're detectable for that the Office for National Statistics aren't yet sure about. So if they don't know, you and me certainly don't know. But we're talking decline after some months, I think is fair to say. Now, figures in England, so this would be December and this would be October. So 12% of the population of England infected or not infected, antibody positive in December, up from 7% in October. Wales, it was 10% in December, 8% in October. So we definitely see this increase in prevalence. And the figures aren't too dissimilar really for Scotland and Northern Ireland, as we'll see. Scotland, so that's December, that's October, December for Northern Ireland and October. So there we see the increase in prevalence. And of course we knew about this anyway, but it's good to get it confirmed with these figures. Now, just to reinforce this with some graphics from the Office for National Statistics, which we have here. Estimate percentage of those testing positive for antibodies from blood samples by month. So we see May, June, July, August, September, October, November, December. But it's hard to give a full number because inevitably, because of the decline in the number of antibodies, some people that tested positive then, by now, will be testing negative. So it's hard to say the total number that have actually been infected, but it's looking probably like about the low 20%. And this is just a regional breakdown. Again, this is not me speculating. This is hard science from the Office for National Statistics. Testing positive from a blood sample in December. So, dear me, Yorkshire and Humber, we do know the cases are up there, and this confirms it. London, North West, West Midlands, and we see the varying prevalence of antibodies there. So given that some people who were testing positive earlier on will now be negative, we can't give an overall number of those that's infected, but my estimate would be low 20s%, and a few others are saying that as well. And that's very consistent with data from the United States, which we're going to look at now. So United States, so we know about the cases and the deaths in the States. But both very high. number of deaths in the States is going up fairly quickly at the moment. Hospitalizations down a little bit, but still at a level which is really unsustainable in many areas. Vaccination program is rolling out. We're expecting 100 million doses in the next 100 days. So under Mr. Biden's administration, this is going to have to bunk up really quickly if he's going to get that in his first 100 days. It's an optimistic target, but it's achievable. I suspect what will happen to begin with, they won't be making 1 million doses. Towards the end of 100 days, I expect they'll be making more than 100 more than 1 million vaccinations per day. So it could well average out at 100 million vaccines given in the first 100 days. That is the big hope for the United States at the moment. But just now, it's so that's the total number of doses given. Of those, 1.7 million have had 2 injections, 0.53% of the American population. So just getting going, really. Now, the projections I want to look at are from the Institute for Health Metrics and Evaluation, Washington University. So let's look at that, Institute for Health Metrics and Evaluation. Do check it out for yourself. They have all sorts of fascinating information on all sorts of places. So I've just picked some specific stuff here to give us an indication of what's going on in the States. Now, this is, of course, about a week out of date because it's always out of date by the time they crunch it. So basically, this is up to about the 11th of January. But as we've seen, thankfully, there's been a reduction in new cases in the United States since the 11th of January. But what's going to happen is the question. So the R number at the 11th of January, greater than 1 in 27 states. So it was increasing in 27 states. It seems to have just turned a corner in the past week to 10 days, which is good. Effective R number, now the less than 1 in most of the Midwest. The Midwest had a great number of increasing cases. We covered that at the time. This would be December, but now the number of new cases there are down, which is good. Now this is the key figure here. Taking into account the antibody studies and the antigen studies and the drop-off in the positivity rate, because people that were seropositive can become seronegative in time, taking that into account, they've come up with this figure of 22% have been infected as of the 11th of January. That is 22% of the entire population of the United States have been exposed to the virus as of the 11th of January. So I think that's an interesting figure. And it just shows without the vaccination programme how early on we would be in this pandemic, as we mentioned. Now, the population of the United States, this is just me sort of extrapolating from this really, 328 million. Therefore, the number of infections is 72 million. So it's a factor of times 3 from the official figures. So that's the official number of infections there as per positive antigen tests. So the real number infected is about 3 times that. Now, we had thought the number might be higher than this. We have thought that the number could be over 100 million Americans infected already. But this data from the Institute of Health Metrics and Evaluation is saying it's less than that. And this is based on firmer data than we had a few weeks ago. Now, if this is the actual number of people that have been, that's the actual number of people that have been infected, and the actual number of deaths we know, so the number of deaths is there as of yesterday, that's of the 18th of January, 394,495. Taking that figure of deaths and that actual number of infections, that gives us an infection fatality rate of just under 0.5%. The case fatality rate, of course, going by those officially diagnosed, is much higher. That's 1.67%. So it looks like the actual infection fatality rate in the United States is just under 0.5%. And this is getting firmer and firmer as time goes by. So of all the people infected in the United States, 0.48, almost 1 in 200, have died of the infection. And that is pretty consistent with data that's starting to emerge from the UK and other European Western countries. So far, I think we can say the infection fatality rate is 0.48. Now, if the pandemic was allowed to carry on running on its own, which of course it won't be because we're going to vaccinate, then that percentage might go down somewhat, because a lot of the most vulnerable people, sadly, are no longer with us as it is. But that seems to be the figure so far. And as we say, case fatality rate from those officially diagnosed, much higher. But that's not the real number because of the many, many infections that aren't officially diagnosed by antigen testing. Now, what this Institute for Health Metrics and Evaluation specialise in are projections. And we have looked at their projections before, and they have been reasonably accurate in the past. This is what they do. So trends, they're expecting a cumulative number of over 500,000 deaths by May the 1st. Now, 567,000. Now, this is very poignant because this means that the death figure will be comparable with the 1918 influenza pandemic. We're talking about overall comparable death figures. Now, this is not set in stone. This can be reduced. We're going to look at that. This represents an additional 192,000 individual deaths from 11th of January to May the 1st. So this is the number that could, and of course, some of these have died already now because we're already on January the 19th. But from January the 11th to May the 1st, they project there could be 192,000 deaths. And unfortunately, we're on track. I wouldn't say to achieve this figure, but for that figure to be realised. They estimate the likely peak of deaths to be the beginning of February. So basically, deaths are going to remain high throughout January. And they say the death peak will be 3,680 per day on February the 1st. Now, this is actually what the deaths are at the moment. The rolling 7-day average deaths in the United States at the moment is 3,680 deaths per day. So what these projections are saying is that this will probably carry on for the rest of January. That's the next couple of weeks. Hopefully peak on the 1st of February, and then hopefully start going down after that is the hope and expectation from this data. And they're saying steady decline after the peak. So, but steady decline. In other words, still a lot of people are going to be dying every day, even into February, and indeed March and April. Reaching about 500, below 500 days sometime in April. So you think it's going to start tailing off. But of course, this is still a large number and still estimated to reach 192,000 by the 1st of May is their projections. Factors, seasonality, going to be a big factor. Less people die in summer, which is good. More people outdoors, more vitamin D being made. And the scale up of the vaccination programme. As of the 1st of May, some states may be close to herd immunity. Now, this is an interesting claim. And that's going to be reached at about 70% with the existing variants of the virus, but it could be 80% if the new variant becomes prevalent. And we are worried about this, and I'm going to give some data for that. So that's what they're saying. Interesting. Combination of people who've had the infection, the 22% who've had the infection, and of course the vaccination programme, hopefully kicking in big time by then. But this is the biggie. If more transmissible variants spread in the US in the coming weeks, peaks could be delayed by several weeks. So that means there could be several more weeks of people dying at the rate of 3,600 a day if the new variants become more prevalent. Not because the new variants are more deadly, but because it just means many more cases because of the increased transmissibility. And the death toll could be substantially increased from this already horrendous projected increase, taking us up to that already very large projected number. Now, this is not scaremongering. This is based on good quality statistical analysis. Hospitalizations in many states will be under severe stress in the next 4 weeks. Well, we know that already. In fact, we know that's the case now. So that's going to carry on for the next 4 weeks. So that takes us into the beginning of February. So as things are, hospitalisation pressure should begin to decline in early February, unless, as we've said, the new variants become very prevalent. To reduce deaths, masks, some social distancing mandates, rapid scale-up of vaccination. So there you go. If everyone wore masks, death would decline. More social distancing mandates, deaths would decline. Depending on how rapid the scale-up of the vaccination programme is, if it scales up rapidly, deaths will be less. So what are the drivers and prevention? Mobility continues to decline, so there's less people travelling around the States, which is good, but still only 33% lower than the pre-COVID baseline, so still quite a lot of people travelling around, but much less. Visits to restaurants and department stores have been up lately, unfortunately. Now, this is bad news. This will cause more transmission. As of January 11th, 76% of people always wore a mask when leaving their home. So getting good, getting better. We still need to be better, but it's encouraging. All states had mask use over 50% up to the 11th of January. United States, 52 people say they would accept a vaccine. To tell you the truth, that's a pathetically low figure, but I'm not too worried about this because we're still vaccinating the people that want to be vaccinated. And I'm sure as more people get vaccinated, more people are going to want to get vaccinated when they see the safety and the benefit of it. So I think that's going to increase, but that's the position now. Surprisingly low, lower than the UK, that figure. We expect 141 to 179 million people to be vaccinated by May the 1st. So 141 to 179 million in that range by May the 1st. Let's hope it's 179 million. That would be a much better range. Now, just a couple of more projections before we leave this bit. I think it is good to know what we're heading for in the next few weeks, really. And of course, a lot of the principles here apply to other countries as well. Projections by May the 1st, 2021, we project that 37,800 to 51,100 lives would be saved by the vaccine rollout. So upper end of the vaccine rollout is achieved, 51,000 lives saved by May the 1st. And of course, lives will carry on being saved for months and years after that, compared to a no vaccine scenario. I'm pleased we've got the vaccines. If universal mass coverage was 95%, as opposed to what it is, which is 76%, 31,000 fewer cumulative deaths. I mean, this is just a stunning figure, isn't it? If 95% of the population wore masks outside, in all public areas, 31,000 fewer people would die. It's up to the United States to decide in terms of wearing masks. And of course, the wearing mask is equally important wherever in the world you are. If a mandate easing scenario, cumulative deaths could rise to 621,000 from that projected figure before, which was what was the projected figure before? 567,000. So if the easing goes on, deaths would become higher, but we're not expecting mandates to be eased. Travel restrictions into the United States were announced to be eased. Were announced that they were going to be eased. Was it yesterday? I think they were announced they're going to be eased next week. But of course, there's going to be a new administration then, and the new administration has made it clear they won't be easing these mandates. So I don't think that's going to happen. I really don't. I really hope that's not going to happen. I don't think it is. January to May, 42 states will have high or extreme stress on hospital beds. So it's going to be difficult in most states. January to May, 45 states will have high or extreme pressure on ITU capacity, slightly more for ITU capacity. So they're projections of what's probably going to happen, and they're probably not too far out. They've been fairly accurate in the past. But the big proviso for the states is the emergence of the new, more transmissible variants. This is what's messed us up in the United Kingdom. Things were going really well. Then this new variant came along and really scuppered things. It's 50% more transmissible. Most data saying now 50% more transmissible. And that just makes a huge difference, as we've seen in the United Kingdom. It hasn't been good in the United Kingdom. So what's going to happen in the United States? Now, this is the Centers for Disease Control have spoken. Now, this B117 is the lineage of the variant that was first discovered in the UK. So that describes the lineage of this virus, this new transmissible form. And as we've said, 50% more transmissible is kind of the figure, which is a big difference. Now, this is the Centers for Disease Control speaking. It's been detected in 10 US states, despite fairly limited genomic monitoring. Potential to increase the US pandemic trajectory in the coming months, obviously. Increased transmissibility of this new, first identified in the UK variant, what's sometimes called the 2012 variant, or the Kent variant, or the UK variant, the one that was first discovered in the UK, although we don't know where it came from. But this just describes the lineage of it, the B117. It's a more technical term. So as a result of this threat, warrants universal and increased compliance with mitigation strategies. This is no time to be letting off. The vaccine is not having a herd immunity effect yet. We need to keep flat out, foot on the gas, I think you would say, for that. Higher vaccination coverage might be needed to achieve protection of the public. So as we said, with the old variant, herd immunity would probably be 70%, but with this being more transmissible, we'll probably need 80% of the population immune through natural infection or vaccination. Genomic sequencing, national SARS coronavirus 2, strain surveillance, targeted approach to identifying variants of new concern in the United States. In other words, the United States have now upped their game on this, and we were expecting a lot more data on this soon, because the genomic sequencing in the United States was patchy. It was patchy. And just to stress this, the CDC have put out one of their little poster credit card things about the risk from the new variant and the importance to wear a mask, stay at least 6 feet apart, avoid crowds, get vaccinated, and of course the one that they should have on here as well, so we'll just use the English one, the British one. Ventilation is also massively important. Now that's pretty well what I wanted to say today. I know that was quite stodgy, but I thought it was important to go through that, to go through some of that data. Now, a few days ago we did look at Brazil, and we did have some distressing video from Brazil, the shortage of oxygen in the Amazonian area. Well, I think this is good news from Brazil. So Oxford AstraZeneca and Sinovac guaranteed emergency use authorization by the Brazilian authorities. Sinovac, 6 million doses already in the country from China, and vaccination has started today. But we believe this is less efficacious than the Oxford AstraZeneca vaccine. The Brazilian Institute are going to manufacture the AstraZeneca vaccine, which is good, but the vaccination program with Oxford AstraZeneca has not yet started, but it should be any day now. So could have done with this a month earlier in Brazil. A lot of people suffering in Brazil through lack of basic facilities. Now, I think what I'll do now, I've got a letter to read you from Texas, but I'm just going to show you a few NHS posters just because I thought they were quite interesting. Here we go. So these are just posters from the NHS. So while the vaccine rollout is underway, hands, face, space, ventilate. I wish they'd put ventilate on there. It's really annoying. So in other words, the vaccination program must not change people's behaviour for some time yet. Stay at home to save lives. That's good. I always think posters are good, actually. I like posters. Sort of infographics. COVID-19 vaccine fact checker. Free of charge. It's a pity that this is needed. There are scams in certain areas, so that's just to prevent scams. That's good. Supplies of the vaccine throughout 2021. That's true. Better to have the vaccine than have the infection. Absolutely. No arguments with that one. people are being informed when they are to roll up for vaccination. I haven't been informed yet. The NHS will inform you. COVID-19 vaccine rollout is based on decades of experience delivering large-scale vaccination programs. Well, this is much larger scale than anything we've done before. But yes, is there experience there? Of course there is. Sufficient doses of the vaccine are available to sustain the vaccine program as it ramps up. That is good. After extensive preparation, the COVID vaccine is being rolled out to millions of people across the UK, starting with those who need it most. Okay, so just a few infographics there. Quite like those. Now, I'm going to show you a couple of pictures now. This is from this is Kylie in Oregon, who's kindly allowed us to see this. But basically, looks like someone is you can't see it. Sorry. Looks like someone's given the vaccine a little low. It should be given high up into the deltoid muscle up in there. So they were just wondering, given it's not gone into a muscle, how effective it would be, because it's been given looks like it's been given a bit low there. So very important that the vaccine goes high in the deltoid muscle, right up there in the body of the deltoid muscle. So someone's been pretty sloppy there. I must say, I'm sorry this has happened to you, Kylie. It's really a bit sloppy to inject too low rather than in the correct place in the deltoid muscle. So thanks for sharing that. That's good of you to share that. Email. I'm a nurse in Texas. The things happening at the local level are outrageous. Things like no longer attempting to keep the COVID patients separate from non-COVID patients. This goes so far as the administration tearing down temporary walls, etc., that were built for a previous designated COVID area. People are not gowning up, etc. It seems out of control, so they've just stopped trying. Now, I'm not saying this is everywhere. This is just one individual's experience. Hospitals and healthcare workers are absolutely spreading COVID-19, no doubt in my mind. There's an overwhelming number of patients in parts of Texas, we read, and the halls are lined with patients on both sides. Sometimes they wait in the waiting room for over 24 hours. Patients with COVID kept in the halls with non-COVID patients. While all are instructed to wear masks, the patients take them off or wear them under their noses. Oxygen supply is only given if when oxygen saturations drop below 90%. The patients are sick and we don't have the staff or resources available to care for them properly. It's difficult to face. And most people caught COVID from acting irresponsibly if they'd listened to scientists! ! Right, she feels she needed to share. Obviously, I can't tell you this individual's name. Not to complain too much, but acetaminophen doses are scheduled as part of the COVID treatments. Now, if you're a healthcare provider in Texas, do tell me if this is true. Is acetaminophen prescribed routinely for all those with COVID? Now, acetaminophen is paracetamol, exactly the same drug. It brings the temperature down artificially. It's an antipyretic. And we've looked at pretty good evidence to say this is a bad idea. So this person in Texas is saying so they give patients acetaminophen on a schedule rather than on a when required basis. So it looks like fevers are being brought down for everyone there. I suspect that's going to have a significant adverse effect on the immune system. My belief is that can increase morbidity and mortality. No lab tests for vitamin D. No social distancing either. There's just no space. There used to be seating that guaranteed distancing, but now all seats are touching and most have someone sitting on them. Most patients admit to visiting family or friends and say they thought they were safe. Right, most patients admit to having visited family and friends and thought they were safe. This inter-household mixing has been a massive driver in the United States. Some even try to refuse to wear a mask, touting their rights even in hospital, but we kick them out. Good for you. So that's the position. Always difficult to read out these emails because they're quite distressing information in them, but that's the difficulty that one individual was having in Texas, so we appreciate them letting us know. If it's not your experience, let us know. We want to get the facts. Okay, thank you for watching this video, of course, as we carry on in the most difficult time of the pandemic in the next weeks.